Hello everyone and welcome to your channel of Pharmacology, where today we will be discussing about an important topic, and that topic is known as clinical pharmacokinetics. So without taking much time, let us begin. So let us first understand what do we mean by the word pharmacokinetics. Now pharmacokinetics, it means that what the body does to the drug. Okay. Now, in pharmacokinetics, we basically study about four components of the drug, and those components are classically known as A, D, M, and E. So, the study of the time course of the drug in relation to ADME, where A stands for the drug absorption, D stands for the distribution, M stands for the metabolism, and E stands for the excretion. This study is known as pharmacokinetics. Now what do we mean by absorption? That the drug, when it is entering into the body, it is known as absorption. How the drug is going to move around in the body, that will be its distribution. How it is going to change itself into the body, that will be the metabolism. And finally, how it will be eliminated, or rather leaving the body, that is going to be the excretion, or the E component, elimination. So with the previous knowledge in mind, now let us understand what do we mean by clinical pharmacokinetics. Again, for the purpose of easy understanding, I have just broken down the definition. The first part of the definition is that what do we mean by clinical pharmacokinetics? So the what component is the clinical pharmacokinetics is nothing but the application of the pharmacokinetic principles. Now which pharmacokinetic principles? The ones that we have studied just before. The core principles, that is absorption, distribution, metabolism and elimination. These application of these pharmacokinetic principles. And where are we going to apply it? The application part will be in the safe and the effective therapeutic management of the drugs for an individual patient. So the definition of clinical pharmacokinetics will be the application of the pharmacokinetic principles to the safe and the effective therapeutic management of the drugs in an individual patient. Now so far we have been dealing with the classical acronym of A, D, M and E. Okay. But some authors advocate that we can change the classical acronym and replace ADME with the new acronym ABCD. Now in this case, A stands for administration, B stands for bioavailability, C stands for clearance and D stands for distribution of the drug. Now these components are more applicable towards the clinical pharmacokinetics. Now the primary goals of clinical pharmacokinetics are, firstly, we have to enhance the effectiveness of the drug. Now students, here also I would like to discuss one more thing. There are two concepts. The first concept is known as efficacy of the drug. Now the efficacy of the drug, it basically determines that the maximum therapeutic potential that a drug can reach. But this therapeutic potential is reached only in case of controlled environments. Okay. So efficacy term is technically given for controlled environments. As for example, suppose a randomized controlled trial, alright, a clinical trial. But in case of real life scenarios, the maximum therapeutic potential of a drug is actually known as the effective effectiveness of the drug. So this one is for the real life scenarios. Okay. So the second primary goal is to decrease the toxicity of the patient drug therapy. And another goal is to adhere to the rather to assess the adherence to the therapy. So these are the primary goals of clinical pharmacokinetics. Now how can we measure the drug concentration, right? So now one thing that we are going to agree is that the effect of the drug is related to the concentration of the drug at its site of action, right? Let us suppose I want the drug to act on the heart. Sufficient amount of drug must reach the heart so that we can get the desired effect, right? Now we want to measure this drug concentration, but the problem is that the receptors are either inaccessible, the receptors on which the drug is going to act. Those receptors are either inaccessible or they are distributed widely in the body. So naturally direct measurement is not an option. Suppose I want to measure the action of digoxin. Now the receptors for digoxin is located in the heart, it is located in the myocardium. Now direct access to myocardium is not possible. So now how can I measure then? How can I measure the concentration of the drug? So there must be some indirect measurement methods, and the samples through which we indirectly measure the concentration of the drug at its site is blood, plasma, urine, saliva. But students, remember a very important concept here. For the indirect measurement, it is of extreme importance that a proportionality exists, a direct proportionality rather, it exists between the site of action and the plasma concentration or whatever concentration you are talking about. Okay. And that proportionality is actually defined by the principle of kinetic homogeneity. So kinetic homogeneity, it measures the predictable relationship between two components. The first component is the plasma concentration of the drug. The second component is the tissue or the receptor concentration of the drug. And what we have found is that there is a direct relationship. There is a direct relationship between the plasma drug concentration and the receptor site drug concentration. That means if the plasma drug concentration increases, then proportionately there is increased concentration of the drug concentration at the receptor or at the tissues. So if you look into this figure, you can see that suppose this is the y-axis and this is the x-axis. So now the y-axis, it has the plasma drug concentration, and the x-axis, it has got the concentration of the drug in the tissues. If you look into this graph, you are going to see that as the concentration of the drug increases on the y-axis, there is, suppose as it is increases, there is proportional increase of the drug concentration on the x-axis as well. That means there is a direct relationship between them. Now why is this very important? This is very, very important because this principle of kinetic homogeneity, which in turn measures the direct relationship between the plasma drug concentration and the concentration of the drug at the receptor of the tissues. This is the foundation for therapeutic drug monitoring. Now students, we have got a detailed lecture on therapeutic drug monitoring. The link for that video will be given in the description box. I urge all of you to please go ahead and check it out. So now let us come to the pharmacokinetic models. Okay. So what we have studied so far is that classically pharmacokinetics has got 4 components to it. The same old mnemonic of ADME. That means these 4 processes, they are occurring continuously. So naturally the process of pharmacokinetics as such is very complicated. But we need to simplify it so that we can predict what is the behavior of this drug. So in order to simplify these complex processes, what we have done is we have developed simple mathematical models. Now for the purpose of these mathematical models to exist, we have divided the human body into compartments. And naturally now the pharmacokinetic models, since they have considered the human body as compartments, hence they are compartmental models. Now those compartmental models, it can be one compartment model, it can be two compartment model, or it can be multi-compartment models. But if you get an understanding of one and the two compartmental models, which we will discuss here, the multi-compartmental models can be very easily understood. Okay. So now one thing about the compartment rather, you must remember that when we say the word compartment, we do not necessarily mean that we are talking about a single organ or tissue or body fluids. Okay. Rather, what we are talking about is a group of similar tissues or body fluids. Naturally, the question that arises here is that how have we compartmentalized the human body? Now the basis of this compartmentalization is the pattern of drug distribution, right? The pattern. So all organs and tissues which have got a similar drug distribution, they have all been kept under one compartment. And the factor that regulates this pattern of drug distribution, that is the perfusion of the tissues. That what is the level of perfusion? Now the highly perfused organs like the heart, the liver and the kidneys, they have got the same drug distribution. So the highly perfused organs, they have all been kept under one compartment, and that compartment is known as the central compartment. There is another compartment which is made up of some poorly perfused tissue, and those components are known as, those compartments are known as peripheral compartments. So in the central compartment you can find the heart, the liver, the lungs, the kidney and the blood itself. And in the peripheral compartment you can find the fatty tissues, the muscle tissues and the CSF. But one thing you are going to notice here is that the drug, it can move from one compartment to the other. There is a two-way arrow, right? So the drugs can move from the central compartment to the peripheral compartment as well as from the peripheral compartment to the central compartment. Now what is the clinical correlation of this body compartmentalization? Now if you look at the aminoglycoside group of antibiotics, these aminoglycoside group of antibiotics, they actually do not distribute extensively to the tissues. Hence, their pharmacokinetic behavior, it can be very well described by a single compartment model, since extensive distribution is not there, right? On the other hand, drugs such as benzodiazepines, they are extensively distributed in the body tissues. Why? Because they are highly lipophilic drugs. Hence, for the purpose of describing their pharmacokinetic parameters, we need some more complex compartments, because a single compartment is not going to suffice, because the drug is not distributed in one compartment, it is distributed in several compartments. Now coming on to the one compartment model. Now the one compartment model, it is the simplest model. This model is an open kind of model. Why open? Because the drug can enter as well as it can leave the body. Now see, if you come into this picture, suppose through this injection I am giving the drug into the blood, okay, and the drug can be eliminated from here. So now the drug is free to enter into the blood. The drug is free to enter into the blood, as well as it is free to be eliminated from the blood. That is why it can both enter as well as leave the body, and hence it is an open kind of a model. Another thing to consider here is that we consider here that the body acts like a single uniform compartment, and the example for this single compartment model is that what happens after the drug has been administered by a rapid IV bolus injection. That phenomenon, that pharmacokinetics phenomenon, it can be explained by a single compartment model. Okay. Now see what is happening in case of the one compartment model. Suppose I am giving the drug here by the IV route, rapid IV bolus, and this whole body, it acts as one compartment, one uniform compartment. So after I give the drug, see what is happening. The drug is getting distributed in this entire compartment. And this distribution is uniformly. Now moving on to the two compartment model. The two compartment model, it divides the body into two compartments, as we have studied already. First is the central compartment, where the drug is distributing itself very rapidly and uniformly. Why? Because the central compartment is the one which is made up of highly perfused organs. The second one is the peripheral compartment, where the drug distributes itself more slowly. And this distribution between the central and the peripheral compartment, it is, we assume that it follows the first order kinetics. Now if you look into this picture, see, this is what is happening. This is how I am giving the drug. So the first, this drug upon giving, it is reaching to those organs which are highly perfused, like the heart, the brain, right? After that, now it is, secondly, it is distributing itself to the more peripheral organs. Okay. If you like what we are teaching, then please subscribe to our channel and don't forget to press the bell icon so that you don't miss out on any upcoming videos. Now moving on. What are the parameters that determine the disposition of the drug? There are 4 parameters. Okay. The first one is bioavailability of the drug. The second one is volume of distribution. The third one is clearance, and the fourth one is elimination T-half. Now students, we have already discussed about bioavailability and the volume of distribution. The link for those videos will be given in the description box. Please check it out. Now the other two parts, the clearance and the elimination T half, we are going to take up in the next part of this lecture. So that's it for today everyone. If you like the video, then please give it a thumbs up and also don't forget to share it among your friends. Also let us know down in the comments below what other topic you will like us to discuss. We will meet you again with more such topics. Until then, goodbye and take care.